It's a true honor to be here. I want to welcome everybody to Houston. We're going to shift gears a little bit. I'm a neurosurgeon, a pediatric neurosurgeon, and I wanted to give you a flavor of a very exciting area in another condition which affects many patients in the world, and give you some of the newer directions that we've seen over the last 20 years caring for these kids with severe epilepsy. It's an absolute privilege to work here in the Texas Medical Center and at Texas Children's Hospital. It's an incredibly impressive place, and I had to come here quickly, and I felt the future of neurosurgery was here at Texas Children's. Nationally and internationally, we're devoted to providing innovation, high quality, and most importantly, attentive care for our children and their parents. We want to train the leaders in pediatric neurosurgery, and we have a great fellowship program and really top-notch fellows that will go out and change the field. And we also want to partner with our research colleagues, and I think that's a very important part of this. In neurosurgery, we're part of a neuroscience center, and the neuroscience center is comprised of neurosurgery and neurology. It's a huge program with many specialists. We cover basically all areas of neurologic disease. We also work closely with Huda Zogby, who runs the Neurological Research Institute, which is part of Texas Children's Hospital. Hopefully you'll be able to get a glimpse of this as you walk around the area. But this is a very important collaboration, and many of the patients that we operate on are being studied in the laboratory by investigators working with Dr. Zogby to try to uncover some of the genetic and biological bases of the diseases that we take care of. Within the Neuroscience Center, we have an epilepsy program. This is not a surgical program, it's not a medical program, it's a combined program. And all of the children that we see here are treated by a combined group of neurologists, neurosurgeons, nurses, psychologists, neuropsychologists, technologists in the care of our patients. This is an incredibly exciting field, and it's one of the many things that we take care of in pediatric neurosurgery. We have a big program in oncology, in fetal surgery, in vascular neurologic disease, in congenital diseases, but epilepsy is huge. And I think that what I've seen over the last 20 years have been two major advances. We are now able to care for many more children who are not candidates for this care 20 years ago. So this represents really a big philosophical advance. And more importantly, when you combine that with some of the technological advances that we've seen, particularly here at Texas Children's, we have technical advances as well. So that allows us to do our surgical procedures safer, quicker, with less morbidity and more comfort for the children, and they can go home quicker. So everyone's happy. So once again, there's been a tremendous shift over the last 20 years where we're seeing children who were not previously thought to be surgical candidates. So the window and landscape is opening wide up. And in addition, we can help many more patients than we previously thought. And I'll get into this concept a little bit later, but I think that the concept of outcome in these children is very different. Why was I interested in epilepsy? Epilepsy is a huge problem. It affects 1% of the population. So in the United States, about 3 million people will have epilepsy. About a third will be refractory to the best of care, which is medicine. And probably, conservatively, about 10% of those will be very good surgical candidates. So we're looking at about 100,000 potential surgical candidates in the United States. In contrast to pediatrics, adult epilepsy surgery, by many accounts, seems to be contracting. This is a niche between tumor surgery and functional surgery, and I think that this is what drew me. So as I mentioned, 1% of the population affected, about a third will be what we call medically refractory. And those are the patients that we are considering in our population to be candidates for surgery. I mean, the concept of brain surgery for epilepsy is very radical. So we have a big obligation to demonstrate safety and to demonstrate that by doing brain surgery, we can help our patients more than medical therapy. In general, we think about epileptic seizure types in two categories. They can either be generalized, where the whole brain is affected all at once. Those conditions are typically not what we're talking about with surgery. We can have palliative procedures that can help those, but what we're really interested in are the partial epilepsies, the focal epilepsies that are affecting one particular area of the brain, and we can target that area with surgery to help the child. Now, the obvious goal of surgery is to control the seizures, but when you bring a child back with their family to the clinic, they talk about that, but they talk about all the other things. My child can now focus. My child can listen in school. My child can attend to tasks. My child can make friends. So epilepsy can have a global effect on the behavior of the child, on the quality of life of the child, and on the family situation. So by controlling the seizures, we're really affecting the family and the quality of life of that family. And this is a very important point to take home. We're not just talking about a surgical technical procedure. So the standard treatment is medication, anti-epileptic medication, AEDs. When these non-operative treatments fail, we consider surgery. The surgery that I'm talking about are really the targeted surgeries where we target a focus in the brain. More palliative procedures are the ones where the child has a type of epilepsy where we cannot pinpoint the focus. It may be affecting the brain in general. And in those situations, we do what's called palliation. We can split the brain with corpus callosotomy to reduce the burden of the seizures. We can implant a pacemaker for the brain called VNS, or vagal nerve stimulator, or DBS, a deep brain stimulator, into the deep structures of the brain to rewire the brain and help with epilepsy. More recently, there's been a responsive neurostimulation RNS closed loop system that we use here at Texas Children that we implant that detects seizures and can shut off seizures once they detect seizures. With drug therapy, as I mentioned, about 2/3 of patients will be controlled with medication and 1/3 will be not. And after you fail the first medication, as you can see here, the chance of a second, third, or fourth medication really impacting the control of that epilepsy goes way down. So the possibility and need for surgery goes way up. Epilepsy surgery, as I mentioned, really relies on localization of the hot spot in the brain where the seizures are starting. And this is a correlation between what we can see on MRI and what we can measure electrically with our EEG. We also have lots of fancy tests that we have in this building here: PET scan, MEG scan, SPECT scan. These are all non-invasive imaging studies that look at the function of the brain and try to tell us where the focus is, because function of the brain is altered in epilepsy. It's not normal. The part of the brain that is having epilepsy does not function normally. The blood flow is not normal. The glucose metabolism is not normal. The electrical activity is not normal. And we use all this information to build a case. And for us as surgeons, we really struggle with this issue. What are we targeting? So the target of our epilepsy surgery can be elusive and makes our job more challenging. But you have to go in to this surgery with this kind of understanding, otherwise we're set up for failure. Now, the way we evaluate these children is what we call phase 1. These children will come into the hospital, they'll get a battery of tests. Most importantly, we take a history and a physical examination. If the child that we're about to operate on this morning, if the child has weakness on one side of the body, that could indicate that the opposite side of the brain is not functioning normally and perhaps the seizure focus is there. We do a whole battery of tests and we try to have a convergence of data. We want all of these tests to point to one area of the brain that we can target with our surgical procedure. And the goals of the workup are very simple. We want to find out where the focus is. So number one, where is the seizure focus? And we have many tests that do that. And then we want to ask the question, can we target it with surgery? Traditional surgery involves going into the head, opening the skull, removing the focus. Is it in a part of the brain that if we go in, it will hurt the child? Will it cause more damage than good? So these are the two things we need to answer with our epilepsy surgery workup. And we do this with a variety of tests. Probably the biggest advance in the 20 years that I've been doing this has been in imaging. So we have the very best imaging here. We have MRI scans that can really peer into the brain and see abnormalities that we could not see before. We have other tests such as SPECT scan, which looks at blood flow of the brain, which is altered in a seizure focus, and PET scan, which looks at metabolism of the brain, such as sugar use, which is also altered in a seizure focus. And those areas will be abnormal as well. And lastly, we have a test called MEG, which stands for magnetoencephalography. This looks at the magnetic waves of the brain, and as you can see here, this cluster in that temporal lobe indicate that that area is spiking. is having a lot of epileptic activity there, and that helps us define what a seizure focus is. When we do all these tests, we then bring the case to our conference, and every Tuesday we have a comprehensive conference where we discuss each one of these cases in detail, and we decide, is this child a candidate for surgery? Should we try more medication? Should we try the diet? And if they are a candidate for surgery, the decision is made comprehensively by the group. It's a consensus group plan that we all sign off on. So the first step of surgery often is what we call this phase 2, where we open up the skull and we implant an EEG electrode right on the brain or in the brain to really fine-tune our focus and map out what's going on. Traditionally, that's been done by opening the skull and placing a large electrode there. It's a traditional brain surgery. More recently, and since I've come here, I've partnered with Dr. Dan Curry, who has pioneered a technique where we don't open the skull. We place the electrodes in minimally invasively with robotic assistance through tiny little holes called SEEG, or stereo EEG. And it's a much less invasive, better tolerated procedure. Similarly, once we have all the information from that phase 2 study, we can then bring the child back to surgery during the same hospital stay and remove the seizure focus by a traditional craniotomy, where we go in and remove the tissue, or paired with this minimally invasive approach, we can go in and instead of removing the tissue, we can treat it with a laser. We can heat it up and ablate the focus minimally invasively without having to open the skull in the MRI scanner, where we can see visually exactly what we're doing. It's quite incredible. We judge our outcome based on very standard outcome measures, and this is the Engel scale. You may have heard this if you read the literature. So an Engel 1 class 1 score is a child is totally seizure-free after surgery, and that's sort of the gold standard. Engel 4 means they're not any different. They're having the same seizures they had before surgery, and 2 or 3 are somewhat improved but not seizure-free. When I started my practice in 1997, epilepsy surgery was well established, but we were operating on kids that had very obvious lesions in the brain. There were tumors, there were vascular malformations, there were perinatal strokes where we would do hemispherectomy, removing one half of the brain. We operated on older children, and as you would imagine, neurological development is critical in the first few years of life. We would operate when we saw one focus in the brain. Interestingly, the first randomized trial in pediatrics was just published last year in India, and this also showed that the surgical group had about a 37% chance of being seizure-free at follow-up compared to the medical group, which had a 0% chance of being seizure-free. So surgery works for children. What I can strongly say now is we've had a tremendous advance philosophically. So we're operating now in the last 20 years, and particularly here at Texas Children's, on children who defy those characteristics. They're younger, they're babies, they have disease affecting both areas of the brain where the seizure focus is much more elusive and difficult to find. These are challenging diseases: tuberous sclerosis, polymicrogyria, MRI negative, where we cannot even see the focus in the brain. And the reason for that is because we have an understanding now that the current course of continuing medical therapy and not stopping the seizures is bad for the developing brain, bad for the quality of life and for life expectancy. There is this entity of SUDEP, of sudden death in epilepsy. I had a classmate in my medical school whose 5-year-old daughter died of sudden death in epilepsy. We also know that epilepsy surgery can not only stop the seizures, but when it's effective, it can improve the neurological development and quality of life of the child. It is safe and it can be cost effective. We also know that our way of working these children up, as I've alluded to, is much better. And it has unmasked children who previously would not have been considered surgical candidates for surgery now. There's also been a growing comfort level with brain surgery as a concept for children with epilepsy. As I mentioned earlier, it's very radical to consider brain surgery for children with seizures. The other option here is, what about children who have seizure foci in areas of the brain that would be considered completely off limits? In areas that control motor function. We now know, based on lots of studies, that the brains of these children with epileptic foci are very plastic, that their motor function and other functions of the brain are affected by the seizures and by the lesions and can rewire themselves. And therefore, we can operate on children who have lesions that previously would have been off limits for us. So lots of advances. Tuberous sclerosis is a fascinating condition that we have a particular interest in. These children get 3 types of lesions in the brain. The cortical tubers on the left are thought to be the source of epilepsy in the brain. This is more common than people realize. It has a very interesting history, and it has a very fascinating genetic basis. There are 2 genetic mutations that are associated with this condition, and these children get benign tumors throughout the body: the skin, the eyes, the heart, the lungs, the kidneys. But the brain is where they're affected most terribly. These kids have very, very bad epilepsy in the first year of life. Most of these children require multiple medications that doesn't control them. It's one of the top known causes of autism. And epilepsy surgery has really exploded in the last 20 years as an option because these children are really refractory to medication. As you can see here, they get multiple lesions in the brain. There's an activation of this biochemical pathway called mTOR that is activated. The 2 genes are thought to be tumor suppressor genes, that when they're mutated, this biological pathway is overactive. Fascinatingly, a drug that controls this pathway, this mTOR pathway, called Afinitor or everolimus, has been shown to shrink these tumors in the brain, and now has been shown to really impact the epilepsy. So we have advances on the medical side here that provide tremendous options for our children with tuberous sclerosis. Now, what was unique about tuberous sclerosis is that these children get multiple lesions in the brain. As I told you, the field was such that we were operating when a child had 1 focus in the brain. So these kids with multiple lesions were being written off. They were not having surgery. They were having a palliative procedure where the surgeon would split the brain, called corpus callosotomy, to really relieve the spread of seizure activity and prevent the impact of the seizures, but really not getting to the source. Now we have some kids these days who have a single focus with tuberous sclerosis, such as this young girl who came here to Houston. We were able to localize her seizures. She had a main focus, and we can take care of that. But the more typical picture for children with tuberous sclerosis looks like this. They get multiple lesions throughout the brain. They're not considered candidates for surgery. What do we do? And once again, when I came out in practice in the late 90s, this was the standard of care. If they did not have a focus that you could measure, they would get a corpus callosotomy, which was considered a palliative procedure. When I saw this child was an infant, was having daily multiple seizures, could not leave the hospital. This child was essentially going to die. And this mother was desperate, and she brought the child. And this was a paradigm shift for us because there were 2 foci on opposite sides of the brain. And we approached that. We operated on this child. This was not a popular decision in my department of neurosurgery, but we felt that we had to publish this. And this child survived and had a dramatic improvement. This was in the top pictures in 2007 when we were invited back to a conference in Pavia, Italy, to discuss this. And the bottom pictures are recent. He now works for the emergency medical services in his town in Italy. And you can see on the lower right, they send me fine olive oil every year here in Houston. And I'm still very much in touch with this child. But this child changed everything for me because we were able to think outside the box and really understand that there were other options aside from a child with a single focus, that there were children out there who defied the typical criteria for surgery that we could help. This is our first 25 patients that we published showing that we could help many of them. About 2/3 of them would be free of seizures in the first 2 years. The way we did this was very intense. We would localize the seizures with open craniotomies. So we took a lot of criticism for this. This was very intense surgery. And I would speak about this often and talk about how it was safe. And I'll talk more about how we do it now. Many centers started looking at these kids more. Instead of just treating them with medicine, this has become now a very exciting area in neurosurgery. And you can see from this paper, many centers are now looking at these children and looking at ways to make it better. And there are many, many examples of this, which I won't go into, in neurosurgery, where we operate to quote-unquote palliate. We know we're not going to get an Engel 1 score, but we do it anyway because we want to help the child, and there's value in that. And in tuberous sclerosis, we can target 1 focus among many and still help the child. And once again, the idea here is that we can help their development. So if you look at this curve here, I don't know if I don't have a pointer, but at the top curve is a graph of normal development. The lower curve, if you see when the seizures start, development goes down. This child is getting worse. You intervene with surgery and they get better. What if they're not seizure-free? Can they still get better, or does their development still decline? There are studies, if you study the literature, this is a review paper that looked at that strongly suggests that being completely seizure-free is not necessary for improvement, that short of being seizure-free, you can still see a cognitive improvement in these children. And I'm sure you've all seen this with your own patients. So once again, going back to tuberous sclerosis 20 years ago, the idea here was the lack of a single surgical target. You can palliate them by splitting the brain and doing a corpus callosotomy. Well, we've changed that notion here. As I've partnered with my partner Dan Curry, we have a targeted palliation. Rather than just doing something very generalized, can we do something that has low risk, where we can target one focus and help the child? And we introduced this notion of minimally invasive surgery for tuberous sclerosis. So it's a combination of this philosophical advance, opening up the field to many more children who were not previously candidates, with a technical advance, so doing a less invasive operation, which, you know, referring doctors, parents would be more attracted to per se. And this is an emerging indication and something that we're doing here. So we pair stereo EEG with laser ablation in children with tuberous sclerosis. And this is a picture of what it looks like in the operating room, right upstairs, up on the 8th floor. We have a surgical robot. Dr. Curry and I are working together. We implant electrodes throughout the brain to target each one of these seizure foci to determine which is the major seizure focus that we can target with our laser or with surgery. This technique is gaining traction. The stereo EEG technique was actually started in Europe and was brought back to the United States by my friend at the Cleveland Clinic a number of years ago, Jorge Gonzalez Martinez, and it's now considered really the future of epilepsy surgery for children. Laser ablation, so basically putting a probe in the brain. It was first done for epilepsy here at Texas Children's Hospital by my partner Dan Curry. This is the first publication from 2012, and he did this in a child with tuberous sclerosis. And now this is something that is drawing patients from all over the country because it is less invasive, and it provides a new option for these children who may not necessarily be seizure-free. So I want to finish with a case sort of to illustrate this point. This was a nearly 2-year-old girl. This surgery was about 2 years ago, more than that, about 2.5 years ago. As you can see from the image on the right, she had had removal of a focus. She had multifocal seizures, and that surgery at another institution did not change her epilepsy, so she was an Engel 4. And we brought her in and we did an exhaustive workup with all the phase 1 studies that I talked about before: MEG, PET, SPECT, EEG, physical exam, MRI, and we studied her and we decided that she was a candidate for surgery. And we placed many electrodes in all of these lesions in the brain. You can see the cartoon here of all the depth electrodes that we placed. This is not simple, but we have a surgical robot that is able to precisely guide us. It's like a GPS system in the operating room to precisely guide these electrodes in the brain. And lo and behold, even though we couldn't detect it on the external EEG, with this deep probe, this electrode, we found the focus. And it was in the right side of her brain. And that was the seizure type that was causing all of her clinical seizures, where she was dropping to the floor and hurting herself. And the family was very distraught. So this is an example of the seizure that we recorded. You can see all the electrodes here. This is a very, very challenging EEG to read by our neurologist, but they do an amazing job here. And we pore over this data together before we consider an intervention. The red dot here is the electrode that was hot. That's the electrode where the seizure was starting. You can see it here superimposed on the MRI. Dr. Curry went in with 2 electrodes with the laser, heated up the lesion, and got rid of it, ablated the lesion. This is now over 2 years later. This was an email from 3 months, but this child is dramatically better. That falling seizure that was hurting the child is gone. Is she seizure-free? No. She still has other seizure types from the other lesions which are minor, but they're not impacting her quality of life, and her development has taken off. So this mother and family are ecstatic. This child is making tremendous progress. Is she in angle 1? No. So by traditional criteria, is she a surgical failure? Maybe, but that's for you to decide. So what we want to end up here is we're giving you a taste of one of the specialty programs here at Texas Children's Hospital. So we feel that children can definitely get better, even if they're not seizure-free. That's a radical new idea. Surgery is safe and can be effective even in babies. We still do traditional surgery, but we do have this less invasive option. Now, because surgery is safer and the risk profile goes down, if we need to do surgery again, it becomes more repeat surgery on the same child. It becomes an attractive option, and we can do this in an iterative fashion where the child can be in and out of the hospital very quickly. So just to end, I'd like to say that I find this an incredibly exciting area. In neurosurgery here, we take care of everything: trauma, tumors, fetal surgery, birth defects. I mean, we have a tremendous array of things we take care of, but I think the epilepsy surgery program really represents the best in collaboration, innovation, and teamwork that combines the philosophical advance with the technical advance. And I thank you for your attention, and I look forward to chatting with you later in the day. Thank you so much.